Okay, well, it's 9:32, so I know some people will still be coming in, but I'm going to kick us off because we have a double billing today. We're lucky to have two presenters, and I don't want to waste more time so that they have enough time. And I'm just going to announce, as usual, our next two upcoming grand rounds. This month on February 23rd, we have Adam Carrico, and he'll be talking about bridging the divide, optimizing biomedical HIV prevention from cytokines to society. That's February 23rd. And then we have one of our postdoc alumni rounds on March 9th, and that will be Omar Martinez, talking about forging sustainable solutions for continuity of HIV care through medical legal partnerships. And Ruben Robbins, talking about making cognitive testing equitable, inclusive, and accessible to diverse populations with HIV. Unless there are any other announcements from anyone, just pause for a second. I'll go on to, I'm going to introduce our speakers one by one, and there will be time for some Q&A and discussion in between, after each one of their presentations. And as usual, that would be moderated by Stephen Sukumaran. So first up, we have Emily Paine, who is a medical sociologist and assistant professor of clinical medical psychology and psychiatry here at Columbia, and in the New York State Psychiatric Institute in our Division of Gender, Sexuality, and Health. She takes an intersectional mixed methods approach to examine social and structural inequities, shaping health, well-being, and access to economic resources among marginalized communities. Her work is, she's on a KO1 award from NIMH. She's highly motivated to understand and develop interventions to address how economic marginalization, race, gender, and sexuality-based oppression and multi-level stigma drive health inequities among sexual and gender diverse people. Emily will be joined today in this presentation by Dennis Rivera-Cash, who is the project coordinator of her study. Dennis has an MPH from NYU and is broadly interested in how social and romantic relationships shape HIV risk and care outcomes for Black and Latinx sexual minority and trans women. And I'm going to take this moment to congratulate Dennis. He was just accepted into a Ph.D. program to continue his studies this fall. So congratulations, Dennis, from all of us. And with that, I'll turn it over to Emily and Dennis.
Okay, thank you, Bob. And congrats again, Dennis. And give me just one moment to share my screen the way Stephen just taught me I could while keeping it in presenter mode. Okay. All right, can everyone see that okay?
Yeah. Yes,
great.
That's good.
Okay, thank you. So I'll jump right in. I'm presenting today on the results of my HIV Center funded pilot. And to first give you some, this is unfortunately not progressing. There we go. Okay. So some background first. Structural inequities have left trans non-binary people shouldering a hugely disproportionate share of the HIV burden in the US. And this is further concentrated, inequities are further concentrated among trans women of color in particular. Trans men are also at elevated risk, although there has been less research focused on and inclusive of trans men. And even less is known about non-binary people, though they are also believed to be at increased risk. Sex with men is the #1 indicator of risk and poor health outcome for HIV health outcomes. And within this constrained community of trans and non-binary people who have sex with men, we also are seeing suboptimal HIV testing, adherence, and viral suppression, as well as low knowledge and uptake of PrEP. So we are also looking at pretty extreme economic inequality that trans and non-binary people are navigating and facing. So we see that a third of people are estimated to be living in poverty. We see 3 to 6 times the unemployment rate compared to the general population. Substantial housing insecurity. So 30% of trans and non-binary people reporting past or present homelessness, and that's compared to 0.18% in the general population. So that's a huge disparity. We also see disparities in home ownership. And again, this is further concentrated among multiply marginalized trans non-binary people who are navigating structural oppression in the forms of racism as well as transphobia, among others. So of course, these come together to increase, or economic disadvantages are linked with increased HIV risk and also poor health outcomes through basically extant research has identified many individual associations between different measures of economic experience and risk and outcomes. However, really what we're missing still is a more holistic understanding about how these co-occurring forms of disadvantage, because we know there are multiple forms at play, right? Which we're calling economic marginalization, is shaping broadly access to HIV prevention and care. So we know that economic empowerment, HIV interventions have been successful in other contexts with other populations that experience similar rates of economic marginalization and high burden of HIV and structural marginalization. These interventions draw from asset theory, which suggests that even very small amounts of resources like cash can be leveraged to improve public health and to improve one's personal health outcomes. Yet there's a clear warrant that such an intervention could be useful for trans and non-binary people in the US who are navigating these high rates of marginalization. But at the beginning of the study, no such interventions had been tailored for this population. So that is the broad goal of this bigger research project. This pilot comprises just this phase 0 of this longer approach. So I'll get back to this later on, but just to show you where we're at. So ultimately, the goal is to adapt and test an economic empowerment intervention for economically marginalized trans and non-binary people living with HIV or navigating HIV risk. But right now we are starting by building our connections with community members and getting community leaders' insight into the experiences of their communities, as well as doing some secondary data analyses. So briefly, the aims of this pilot were to describe and characterize economic marginality and to estimate and qualitatively explore how that economic marginality is shaping and associated with HIV outcomes. So we're doing this in 2 ways. The first way is that we used existing data, so baseline data from the Project Affirm study led by Walter Bachting. This is a longitudinal cohort study of 330 trans and non-binary people living in New York City, Atlanta, and San Francisco. And we use this data to do a mixed source principal component analysis to capture latent measures of economic experience. So how different forms of economic experiences are sort of hanging together to and associated with our outcomes of interest, which in this case are access to healthcare, HIV testing, and status. And then we also recruited and interviewed, primarily Dennis, recruited and interviewed 37 trans and non-binary community leaders. So these are people with experience, they're leaders in their communities in each of these 3 cities, and to ask about their perspectives on community economic well-being, how this connects to HIV prevention and care, and also to get a sense of different economic empowerment strategies that could be most useful in their communities. So for our quantitative analyses, we worked with the data available to us, right? This is an exploratory study and a secondary analysis. we started off with a very conservative proxy for sexual risk. So that is sex partners within the past 5 years. And then we brought in multiple measures of economic experience. So income, education, employment, and then we also had measures like debts, which was a question that asked, would you have money left over if you paid all debts? Enough, meaning would you have enough money to pay for basic needs? We looked at housing precarity in the form of times moved in the past year, and also whether or not people experienced homelessness or stayed in a shelter in the past year. And then we were interested in how the latent measures of these multiple forms of economic experience may be associated with access to healthcare and then HIV testing and status. So the first thing we did is we stratified the sample by sexual risk behavior, again, which is just this very broad measure, which is whether or not, in this case, we asked people if they'd had sex with cis men, trans women, or non-binary people assigned male at birth in the past 5 years. So in this first column, you see no, these are people who answered no to that question, and in the next column, it's yes. So just briefly, what I want to draw your attention to here is that trans and non-binary people of color in the sample are overrepresented in this risk group, right? And also as are trans women. But I also want to draw attention to the fact that 25% of this sample reporting sexual risk are actually trans men, and over 15% are non-binary assigned female at birth, which again points to the importance of doing inclusive HIV science research, right? Again, we see that here in the column where people are indicating risk, we have overall lower household income, and also, this isn't shown, but more people living off of that household income. We also see that people are less likely to report that they would have money left over after paying all debts. We see there's more housing precarity in the group indicating risk. So people moved more times in the past year. They weren't more likely to report experiencing homelessness in the past year, but I do want to just draw your attention to that there's 6% of people who did not report risk and 8.3% of people who did, who are reporting homelessness just in the past year, which is significant. And then again, we see that people indicating risk are more likely to report that they will not have money to cover basic needs. So we're already seeing, right, that there is more and more forms of economic disadvantage that are concentrated within trans and non-binary people who are reporting some risk. Okay, so then we have, in terms of our outcomes of interest, we see there's no difference between groups here, but that about a fifth to a quarter of the sample are reporting avoiding care either due to cost or disrespect. And there's no difference between the two groups in access to trans competent care, and which makes sense, right? We see that HIV testing frequency people are testing more frequently in the group reporting risk, and also that people in this group are more likely to report living with HIV. Okay, so next we have, excuse me, there we go. So next we did this mixed source principal component analysis, and that allows us to use both categorical and continuous measures to put together and assess how how these different variables load onto different factors. And this gives us, again, a sense of like a latent factor of multiple economic experiences that hang together in brief. So, and Jordan Dworkin, it helped us with this analysis, and unfortunately he has left NISP, but we thank him for that as well. So what emerged from this were basically two factors, and we called one an SES factor and one the precarity factor. And that's because in this first factor, variables related to education, income, and full-time employment loaded most strongly onto this factor, which we consider sort of a traditional socioeconomic measure. On the second factor, we have variables related to debts, not having enough resources, precarious housing, and homelessness. So this is, those all loaded most strongly onto the second factor. And so we've titled that the precarity factor. And that's, again, housing and asset precarity. So first, with the whole sample, we looked at whether scores on these two factors were associated with whether or not people reported sexual risk. And so this does show that participants with higher precarity scores, so again, more likely to report housing precarity, lack of assets, that these folks were more likely to report sexual risk. So again, we're seeing now we're starting to see some forms of economic disadvantage concentrated among people who are reporting sexual risk again. Briefly here, I just want to, so starting from here on, we're only looking at the people who are reporting sexual risk. So that's the subsample is 229 people. We do see that, and these coefficients are showing increases or decreases in the latent factor scores that are associated with a change of category, or in the case of age, 1 year increase. And so in brief, this is showing that racial and ethnic minorities participants had lower scores on the SES factor, so lower on those measures of income, employment, right? And then higher scores on the precarity factor. And then also we see that trans women, in comparison to trans men, had lower scores on the SES factor. So now we're looking at our outcomes of interest. And so what we see here is that participants with higher scores on the precarity factor were more likely to report avoiding healthcare for fear of mistreatment. And then in the second column, this is after we have adjusted for potential confounders, those covariates we showed earlier, and that remains. And then we also see that people who had higher SES scores, that was associated with a lower likelihood of avoiding care. And this is for avoiding care for fear of mistreatment. We looked at also avoiding care due to cost, so not being able to afford needed care. And again, people with participants with higher precarity scores were more likely to say they avoided care for cost before and after adjustment. And here we look at access to trans-competent care, and people who had higher precarity scores, again, had lower access to trans-competent care. And also people with higher SES scores had more access to trans-competent care. So when we look at HIV, again, this is an exploratory study. It's not powered for these specific questions, but we do see not significant at the 0.05 level, but we do see a trend towards people who have higher scores on the SES factor, reporting that they are not living with HIV. And then here we see that people who have higher scores on the precarity factor are reporting more frequent HIV testing. Okay, so what does that all mean? So basically, we revealed two latent components of economic experience, one related to traditional SES measures, such as income, education, and employment, that might be more often accounted for in social science research. But then we had another one emerge related to debts, access to enough money to cover basic needs, and precarious housing, which we called precarity. Higher precarity scores were associated with lower access to healthcare for cost, avoidance of care due to mistreatment, and also lower access to trans-competent care, but more frequent HIV testing. Not significant again, but also suggests that higher SES scores may be associated with HIV negative status. So altogether, it's demonstrating the usefulness of assessing these co-occurring forms of economic disadvantage to better understand these broader risk profiles and contexts, and also the need for more formative work that's designed specifically and powered specifically for this focus. And also brings our attention, highlights, right, precarious housing, and these really what aligns with asset theory's idea that people need access to cash, enough to live on, having savings, these sort of small measures of resources that don't always figure into our research models. Okay, so we have time. I'll introduce our qualitative work now, and then Dennis is going to present his some findings that he's writing up as a paper. So first, our approach was to connect with community leaders. We ended up interviewing 37 community leaders from 2021 to 2022. We took an abductive analytic approach and a flexible coding strategy. And participants tended to work across different orgs by and for trans and non-binary people. They had done this work for sometimes over 20 years and served on multiple boards. So they had a breadth and depth of community knowledge. I was a broadly diverse sample, so diverse by race and ethnicity. We spoke to people who were 25 to 70 years old. People were spread across these 3 cities, Atlanta, New York City, and San Francisco. And in terms of gender, we primarily spoke to women, trans women, or women of trans experience. But we also importantly spoke to trans men and non-binary people. Okay, and now Dennis is going to take it away and share about this secondary analysis he's doing.
Right, thanks, Emily. Yeah, so as Emily previously mentioned, the HIV burden is higher among trans and non-binary people who have sex with men, and having sex with cisgender men has been found to be the strongest predictor of HIV risk behaviors and HIV infection among trans and non-binary folks. And so I conducted a secondary data analysis of the pilot qualitative data to take a closer look at the romantic relationship context. And so this research question guided my analysis. How do romantic partnerships shape the economic well-being and sexual health of trans and non-binary people? So more specifically, how do these types of partnerships shape their economic marginalization and affect their HIV risk and care outcomes? And so through my analysis, 4 major themes came up. So the first theme speaks to gender-based stigma and violence. So participants noted the negative influence of gender-based stigma within relationships, as it may often result in cisgender male partners perpetuating violence against their trans and non-binary partners. The second theme touches on structural barriers in romantic partnerships. And so participants indicated structural barriers such as discriminatory housing, healthcare, and policing policies considerably kind of impact how trans and non-binary people establish and navigate romantic relationships. Is the next slide. Yeah, so the third theme that emerged highlights economic dependence on romantic primary partners. So this particular quote came from a community leader in New York City, and so I'll take time to read that for us. And so, well, I think a variety of things. First of all, those who are actually engaged in sex work right now obviously are at a much higher risk of HIV infection and other STIs than those who aren't. But even those who are not engaged in sex work, some may be dependent on a partner financially. And who knows, maybe this partner might pressure them to engage in unprotected sex. What if the partner is actually having unprotected sex with other people as well? So there's a whole bunch of layers to this. And so the financial dependence on a partner also relates to pervasive discrimination, right? Because if one is partly or entirely financially dependent on a partner because they can't find gainful employment because of transgender related discrimination, then obviously that puts them at higher risk for HIV and other STIs, as well as for intimate partner violence, for possible homelessness if they're kicked out of the home. And so this quote kind of reflects the interplay of economic dependence and gender-based discrimination and how these factors may influence HIV risk in the context of romantic relationships. So next slide. Yeah, and so the last theme that emerged focused on HIV prevention interventions targeting romantic primary partners. So participants highlighted the importance of including heterosexual cisgender male romantic partners in HIV prevention interventions for trans and non-binary folks, as cisgender males historically have been overlooked in HIV prevention initiatives and interventions, and this group tends to underestimate their risk for acquiring and transmitting HIV. So
Okay,
yeah, I'll take it
great.
back.
Thank you so much, Dennis. And Dennis is going to hop off in a minute to go to his next PhD program interview. So thank you so much. Okay, so we have done initial rounds of coding on the rest of, so we brought in Dennis to present this secondary analysis because he had to take off. And now I'm going to talk about the primary analyses. So these are still in progress, but we have completed the first round of analyses, and this is what we've found. So multiple reinforcing barriers to economic well-being are challenging community members' abilities to diminish HIV risk and access HIV prevention and care. So this is looking at the community economic health and well-being from the perspectives of community leaders. So the primary barriers that community leaders identified included, one really big one was safety, and this is across domains. So in relationships, housing, work, and in the public sphere, there's a significant fear of racialized transphobic violence against trans women of color in particular that is marginalizing folks in a variety of ways. There is a lack of access to cash and savings for basic needs like food, transportation, and also access to banking, which in and of itself is related to this next item, which is safe and affordable housing. So, you know, as an example, people noted that particularly for people doing sex work, having the option to do webcam work in the safety of their homes, needing basic items like refrigerators to keep meds in. There's an example of people living, you know, in SROs in the Tenderloin in San Francisco with only shared bathrooms, no places to cook. So really housing emerged along with safety and savings as sort of the primary issues. People also highlighted the need for access to high quality health insurance and high quality mental and physical health care, employment again, and also that there's a lack of access to gender affirming care, which in turn impacts employment options, lack of access to safe and non-discriminatory education and educational environments, and overall, the central role of discrimination and how that is working to economically marginalize people. So in terms of family rejection, leaving people early on without access to resources or a safety net, and then workplace discrimination, which marginalizes people from the workforce as well. And so in these ways, these community leaders discussed that these are working to increase risk and limit engagement in care. And to that, I want to share one sort of longer quote that exemplifies how these experiences work together to influence people's HIV risk and engagement. So one participant said, housing, education, and safety. The reason why I said those three is because I went to City College myself. I've seen it. The day after they had the transgender day, they bring all the girls out there and they show them the campus, try to make them feel comfortable. And I've seen guys heckling them and saying things they shouldn't be saying because words are also harmful. And the thing about transphobia is it is instilled in generational passing down of isolating or segregating the trans community from the larger subculture and not making them feel welcome or feel that they have any value in the community. So therefore, they don't feel they have anything coming from being around those people or letting them into their circle, which keeps them living in the shadows and keeps them at risk, keeps them at higher risk for infection, as well as being exploited and taken advantage of, because as long as they're in the shadows, they're taken advantage of. There are men who develop secret relationships and support them by giving them money and trying to keep them hidden away from the world where they can still remain who they think they are. And this cycle will never stop until we can actually get them on a level playing ground. And I think the level playing ground would be through education and housing and creating some kind of way to keep them, to make it safer for them if there were stronger laws. So again, this quote really, she walks us through the ways in which discrimination across sectors is keeping people marginalized and how in that marginalization is also leading to precarity and increased risk. And noting that these factors exist across multiple levels, right? Laws, interpersonal relationships, educational institutions. So we also discuss intervention strategies, and leaders endorsed a variety of economic empowerment strategies. There was a lot of enthusiasm for this, this idea and this concept and support. So some things they thought would be important to include were peer-led interventions targeting economic, mental, physical, and social well-being. So a more holistic approach and importantly delivered by peers. With an empowerment focus, cash transfers were supported, as was financial literacy more broadly and goal setting, job readiness and vocational training and placement, housing assistance and connection with safe housing, broader skill building and educational support, reconnecting people or connecting people for the first time to care and social services, encouraging social support, and that HIV as a focus of these interventions was acceptable, but primarily needed to be affirming and non-stigmatizing, and again, delivered by community. They also noted things to avoid, including, some of this is just the flip of, right, the previous list, but not having peers deliver interventions, avoiding a one-size-fits-all design. They really emphasize the need to meet people where they're at, avoiding exclusive designs, for example, not including transmasculine people or not doing a status-neutral study, avoiding people needing ID documents to take part. So, for example, social security number, avoiding stigmatizing approaches, and also short-term approaches. They emphasize the importance of building long-term involvement and empowerment for trans and non-binary communities. So altogether, leaders shed light on how these multiple structural forces, including transphobia and racism, are working in concert to economically marginalize trans and non-binary people. They told us some dimensions that were the most important to focus on among their communities in terms of people's economic disadvantage and experiences. They indicated key things to consider as we move forward in identifying and developing interventions. And when we bring this together with the quantitative findings, it also calls for, right, continued community collaboration and also formative work to better understand the experiences of trans and non-binary people who are currently economically marginalized, particularly along these lines that emerged in our findings. So this is our sort of approach that we're taking into the next steps of this study. This is an integrated asset theory and social ecological model of economic marginalization and HIV prevention and care. And so we are looking at, again, these forces across multiple spheres. Societal, we have laws and policies, structural stigma and discrimination, structural racism as well, interpersonal exposure to discrimination and IPV, and access to gender affirmation and support. And then we are hoping to intervene on these individual, how these upstream structural forces are materializing at the individual level. So that includes multiple aspects of economic experience and also HIV risk behaviors and outcomes. So we are now in this second phase. And as you can see, this is a long study. It's a 5-year plan. And that is because of how important we know it to be to work with community members to do this work and ensure that we're developing a study, or rather an economic empowerment intervention that is extremely well tailored to community needs. And so at this time, we are convening our community collaborative board, and then we will together finalize subsequent study phase design. So with that, I just want to say a very special thanks to the people who spoke with us and who continue to work with us on the next step of this project. And that's all.
Thanks, Emily. That was really great. We'll jump into the Q&A portion now. As a reminder, if you have a question for Emily, you can enter it using the Q&A feature at the bottom of your Zoom window, or you can also use the raise hand feature and I will unmute you. We have one question already from Victoria Murray. They asked, do you have any suggested approaches for housing for trans and non-binary individuals in gendered residential substance use disorder treatment? I think you're on mute.
All right, there we go. Do I have suggestions for approaches? I mean, so what I would say is, based on our findings, we didn't ask specifically about this issue, but again, the most important thing is to go to community members and to get their perspectives on what's the most important way to proceed in this way. So issues like substance use definitely came up in our conversations, and that is a sub-focus that community leaders urged us to include in next steps. But I can't say I have like a specific, I don't have specific advice for approaches in gendered residential substance use disorder treatment, except that it should be tailored according to local trans and non-binary community leaders and their perspectives. Yeah.
Sure. And if there are others in attendance who can chime in, please feel free.
Yeah, and I was just going to say, I do think we have some of the community collaborative board members here today. If anyone wants to chime in, you're more than welcome to.
Perfect. Feel free to raise your hand. If I don't get to you now, we'll circle back. We have a question from Brian Kuttner. Brian, go ahead.
Hey, Emily, this is really, really interesting. I'm so happy to get to see your work and how thoughtful you've been in creating that model. I have a question about the project firm quant data that you were working with for the secondary data analysis in the first part. I was just curious if you have any thoughts about what kind of variables you might want to add in the future quantitatively that are either informed by the qualitative or that might, I don't know if there's any concern particularly about selection bias in terms of the sample. I don't remember the different cities where people were, but if there are any like concerns about rurality or geography or something like that that might inform future interventions. I'm just curious about that.
Yeah, so first of all, thanks, Brian. This is definitely focused on people living in like 3 specific urban environments. And even across those, there's tons of variation in people's concerns, partly, right, because the policy landscapes in somewhere like Atlanta is really different from the policy landscape in New York City, which is also different from that in San Francisco, although they have more in common, right? So I do want to just say that like it's very location specific, and the concerns that people have are location specific, which also speaks to that, the need to have to avoid a one size fits all design, which is difficult, right, when we're trying to create interventions, standardized interventions. But so when it comes to rurality, yes, like these are not the same concerns that people's experiences are just qualitatively different, who are living in rural contexts versus these 3 cities. As far as measures that we want to include, we're sort of like in the deep end with that right now. So yeah, I think it's exciting we are going to be launching our own survey, and we will start by building from the project to firm cohort, but not everyone will be eligible, and we will be doing additional recruitment for that survey. So it'll sort of branch off. And yes, we will be crafting questions again in collaboration with the community collaborative board, but based on these findings, definitely more questions about housing experiences. So like what type of housing people have been in, how they were, why they had to leave certain housing situations. So getting more about housing dynamics, I think, will be important. Also getting more information about employment experience, training, and then more information about how different exposure to discrimination and structural oppression is informing these sort of like turning points, economic turning points for people. So we'll be trying to address that through the surveys, but also we'll have interviews that we're doing as well. So we'll have another sort of mixed method approach to getting that information. Did I answer your question?
You very thoroughly did. Thank you.
Thanks, Brian. Any other questions? If not, Bob, I'll turn it back to you. Thanks, Emily.
Thank you.
Okay. Thank you, Stephen. And thank you, Emily. That was, I agree with other people commented. That was great. And it's so nice to see these great outcomes from one of our center's pilot studies. So thanks for sharing that with us. And you did it in great timing with even minutes to spare. So thanks for that. Okay, let me introduce our next presenter coming up now, and that is Fernando Montero, who is currently a T32 postdoctoral research fellow at our HIV Center. His research draws together the methods of medical and economic anthropology to examine the racialized, gendered interface between the opioid overdose epidemic, mass incarceration, ongoing transformations in narcotic supply chains, and public assistance programs for psychiatric disability in the United States. He also engages in mixed methods, and his studies are looking at contemporary changes in the risk environment for HIV, HCV, and mental health conditions, and fatal overdose among street-based people who use drugs. And this includes transformations brought about by the emergence of synthetic sedatives and stimulants in the last decade or more. And by the simultaneous resurgence of punitive drug control targeting petty dealers through the United States. So you can see the layers of complexities that he's examining. One of the central questions guiding his current research is why the opioid overdose epidemic is becoming increasingly Black following almost 3 decades in which it was predominantly white and working class. So very timely, very important. We look forward to what you have to share with us, Fernando, and I will turn the floor over to you.
Thank you very much, Val, for that very nice introduction. It's a pleasure to be here. It was a pleasure to listen to Emily's presentation, and I would like to share some slides with you. 1 second. Can you see this?
Yes, but we're not in presentation mode. We're seeing all the slides
Right.
on the left.
Right. Okay.
Yeah, that looks great.
So as Dr. Remien mentioned, I am a medical anthropologist. I am a Ph.D. 32 postdoctoral fellow at the HIV Center for Clinical and Behavioral Studies. I am working very closely with Nabila El Basso, who is my scientific mentor. I'm becoming increasingly involved in her healing community study in 10 rural counties in upstate New York. Dr. El Basso is the PI for this project, and I'm very excited to be a part of it. I have, just as a brief introduction to myself and to my project, I have 15 years of experience doing research on narcotics economies and people who use and inject drugs in the United States. Between 2007 and 2012, I lived in North Philadelphia in a predominantly Puerto Rican and Black neighborhood known as Kensington. That was the most important industrial center in Philadelphia between the mid-19th century and the mid-20th. But that with deindustrialization soon emerged as one of the poorest and most underserved neighborhoods in the city. And today it hosts the largest open air drug market for opioids, stimulants in the tri-state area of Delaware, New Jersey, and Pennsylvania. I moved to New York in 2012 for graduate school, but I have continued visiting Philadelphia, maintaining my relationships with my neighbors, maintaining conversations with people who use drugs, most of whom are homeless. Essentially, as soon as the COVID moratorium ended in 2021, I returned to Philadelphia to see the impact that COVID was having on the neighborhood. And through my conversations with people who use drugs, I quickly learned that the opioid supply had changed tremendously between 2019 and 2021. And one of the most important changes was the fact that there was a new opioid adulterant that people were calling tranq. And that is the adulterant that I am going to be talking about today. Interestingly, with my research team, I did this research in Philadelphia with a team of medical anthropologists, Philippe Bourgois, Laurie Hart, George Carandinos. I owe a great deal of what I know about ethnography and about narcotics economies to them. And interestingly, I had traveled with Philippe Bourgois to Puerto Rico in 2011, and we had already come across Xylazine as an opioid adulterant. And I will mention to you, I will describe to you in the presentation some of what we learned from our Puerto Rican collaborators and from the Puerto Rican public health literature that we are now applying to our analysis of Xylazine in the mainland United States in the current era. So Xylazine, as many of you might know, is not an opioid. It's an alpha-2 adrenergic agonist that has long been used as a veterinary analgesic, sedative, and muscle relaxant for large animals, predominantly horses and cattle. As a heroin adulterant, it was first documented in rural Puerto Rican towns and cities in the early 2000s. Many of the horses that compete in races in the mainland United States are bred in rural Puerto Rico, and xylazine is used not just for veterinary purposes, but also in order to transport these horses more easily to the mainland United States. So the Puerto Rican public health literature was really the first to identify a link between xylazine adulteration, the risk of overdose due to respiratory depression. Xylazine is a respiratory depression, just like opioids. And this literature was also the first to identify novel types of soft tissue infections associated to xylazine use. These wounds or infections are not abscesses, and the Puerto Rican literature was always very clear about the fact that these new wounds could be referred to as ulcers. They were the first to propose that these ulcers were being caused by the lack of oxygenation to the skin, and several new clinical medical hypotheses have emerged in the last few years as xylazine becomes increasingly prevalent in the mainland US drug supply, but we still have not been able to determine, and the literature has still not been able to determine exactly what causes these wounds, which are sometimes extra local. They appear in limbs far from the sites of injection, and oftentimes even people who only sniff and do not inject develop these ulcers. Some of you might have seen an article by the New York Times 2 weeks ago that included many photographs of these ulcers, and the photographs are very graphic, very gnarly, and you might have been able to see how far they spread in the body. Some doctors in Philadelphia are proposing that these wounds are partly a result of concrete bruises, and we would normally traditionally refer to these as bed sores, but people are not sleeping on beds for the most part. The people who inject drugs that I speak to in my research are predominantly homeless and fall into a deep slumber after xylazine consumption. Xylazine induces a deep sleep in many occasions, and people basically pass out on the concrete for long periods of time in awkward positions. And some doctors are hypothesizing that sleeping in these awkward positions for extended periods of time are helping to produce these extended wounds. So as soon as I learned about this, again, right after the COVID moratorium in early 2021, my team and I thought that it was very important to get the word out. And so we began to call jurisdictions across the country, along with our epidemiological collaborators, including Chelsea Shover, Joe Friedman at UCLA. And we published an article using the data that we were able to obtain at that moment in time. Not a lot of jurisdictions were testing for xylazine. We obtained this data from medical examiners' offices who test when there's an instance of an accidental drug overdose, a fatal drug overdose. And the data that we were able to obtain is not exactly symmetrical. Sometimes we were able to get data from a state jurisdiction, sometimes from a local county jurisdiction, right? So some of this data will appear inconsistent to you, but the reason for that is the fact that we were kind of rushing to get as much data as possible to get the word out about the spread of this new adulterant that needed to be addressed specifically. So we found that in the 10 jurisdictions that provided us data, xylazine was increasingly implicated in overdose mortality, rising from 0.36% of deaths in 2015 to 6.7% in 2020. The highest xylazine prevalence in fatal overdoses was observed in Philadelphia in 2020. 34.7% of overdose deaths already involved xylazine. The state of Maryland already had 19.2%, Connecticut 10.2%. These numbers have risen since And in our continuing research, we are very much interested in updating these numbers. There's no question that xylazine has now spread to New York State, other parts of the Rust Belt region, in particular Ohio. And we are very much interested in continuing to trace the spread of this substance. And something that's very interesting is that xylazine and fentanyl generally go hand in hand. You can't simply go out to a corner to buy xylazine. What you're buying is what is advertised as dope. And increasingly, that dope is a combination of fentanyl and xylazine. And as you can see, in 2020 in Philadelphia, fentanyl was present in 98.4% of xylazine-involved overdose deaths. So again, they almost always go together. This is generally the data that we were able to obtain from the years 2015 to 2020. I would be happy to provide this data to anybody who is interested. But as you can see, Philadelphia at that point was by far the jurisdiction that had the highest number of overdose deaths involving xylazine, both in terms of number and in terms of percent. So why is xylazine emerging today as an opioid adulterant or enhancer? And how do people who use drugs understand the transformations unleashed by xylazine? So I thought this was a particularly interesting and insightful description by one of the people that I spoke to, a homeless person who injects drugs in the neighborhood of Kensington. He explained that fentanyl is such a short-lived high that it's a good high, but it's so short that the knot is over real quick and you get sicker faster. C, the tranq extends the high. It gives the dope more of a heroin effect. It's a good rush with a heroin-like legs, which is a word that is used commonly in Philadelphia to refer to the length or duration of the high. But they straight put bangs out there that are just all tranq, all xylazine. You shoot it, you feel no rush. Tranq fent is like you shoot it, you get the rush of the fentanyl, then the tranquilizer comes in, you nod, and you fall asleep. A straight tranq bag is like you shoot it, you get no rush, you're sitting there for a second talking, and then you're waking up 2 to 3 hours later in a weird position. Like one case, I lit a Newport, a menthol cigarette. I shot a bag with a Newport. I woke up with a whole Newport burnt into my stomach. You could literally drown in a ½ inch of water if you did a tranq bag and you fell out. So one of the things that this statement helped me realize is that fentanyl adulteration actually introduced many problems to the opioid supply. In addition to being a very potent respiratory depressant, and this has been well documented now in the literature, fentanyl has a much shorter metabolic half-life than heroin. So it shortens the duration of the high, and more importantly, it quickens the onset of withdrawal symptoms, right? And people, as Tom explained in the quote, it makes you sicker faster. So you need to inject more, you need to buy more, and sometimes when you can't find money, you have to experience more severe withdrawal symptoms, and that has always been seen as a problem of the fentanyl era, as a matter of fact, despite the fact that some people have come to enjoy the specific rush of fentanyl. One problem that affects mostly supply and not just people who use drugs is the fact that fentanyl, because it is such a potent respiratory depressant, cannot serve as the bulk of the substance that is sold as dope in the street market. It cannot be the diluent, the main diluent, because it would kill off the user base. And xylazine, even though it is a respiratory depressant, is a weaker respiratory depressant than fentanyl, and it can serve as a diluent or as a bulk of the substance sold as dope. And the most recent testing data from Philadelphia is showing that the average dope sample in the city is comprised, again, on average of 2 to 10% fentanyl and 30 to 40% xylazine, right? So again, xylazine is now the bulk of the substance that is being sold to people who use drugs. alongside a little bit of fentanyl, which is the opioid. And it is important that xylazine, because of its long metabolic half-life, extends the duration of the sedative effect. And so people don't need to buy as frequently, don't need to inject as frequently. And people talk about appreciating that aspect of tranq. It gives fentanyl a bit more of the heroin-like legs, right? The duration of the high. It's also interesting, you know, when it's become very common to just say that fentanyl is more potent than heroin, right? But I really insist that that's actually a very poor description of the difference between fentanyl and heroin. And this becomes crucial when trying to understand xylazine. Because another thing that people who use opioids regularly tell me is that fentanyl is also a very different kind of high than heroin. So aside from that, it's increased potency with respect to respiratory depression and the fact that it's short, it has a shorter duration. The high is also qualitatively different. People used to describe heroin in between 2008 and 2012. Heroin in Philadelphia was extremely pure. It was a form of Colombian heroin that was very potent, and people described it as an all-encompassing bodily experience, like a holistic bodily embrace. Fentanyl instead is described as a much more local high, as something that is concentrated in the neck and the face. People describe it as a kind of flushing feeling in the face. And xylazine has come in to kind of mimic heroin a little bit more in that respect as well. Xylazine is described as a holistic full body experience, a full body sedative effect. So the combination of fentanyl and xylazine makes up for some of the deficiencies that fentanyl introduced in the experience of people who use drugs. As well in the more practical transformations related to the duration of effect, right? People don't get sick as fast, and that's very important to people who are homeless and who consume opioids on a daily basis. So as I mentioned, there's a very interesting, very, very useful, very important new drug testing program in Philadelphia that is beginning to document the relative concentration of xylazine and fentanyl in the local dope supply. And I would be happy to provide you with a link to the data, which is publicly available and released on a quarterly basis. And this is where we're learning that the opioid supply in Philadelphia today is 2 to 10% fentanyl, 30 to 40% xylazine. So now, even though xylazine compensates for these deficiencies introduced by fentanyl, it also unleashes a new set of problems, right? So number one, xylazine is not an opioid. It's an alpha-2 adrenergic agonist. So there is a need for new overdose reversal agents. Naloxone is not going to be enough anymore. And you can see that on the street, the increase in anxiety over the fact that there's a new substance that is also a respiratory depressant that cannot be addressed with naloxone alone. There are reversal agents that have been used in veterinary contexts for a long time, but they have not yet been tested significantly in humans. So there's a lot of work to be done in that respect. These new skin infections known as ulcers are also a significant new problem that hospitals in places like Philadelphia are increasingly having to deal with. Another problem, and this is one of the major transformations that xylazine has unleashed for the harm reduction landscape, has to do specifically with women who are homeless and inject dope. They tell me that they're increasingly concerned about the possibility of sexual assault and robbery due to the deep sleep that xylazine induces, right? So even though in a harm reduction context, we would normally encourage people who use drugs to try to inject in the company of others to prevent an overdose, women are beginning to see injecting alongside others as a risk in itself. And so that complicates harm reduction messaging. And of course, it also contributes to the reasons for needing more overdose prevention centers or safe injection sites, right? It's not now just a question of preventing overdoses, it's also now a question of preventing sexual assault for people who are going to fall most likely into a deep sleep for a few hours, given the state of the drug supply today. And then there's questions that have to do not just with overdose, but also with the treatment of withdrawal and detox. A lot of patients are coming into Philadelphia hospitals and clinics with these extended ulcers all over their bodies. And they are interned in the hospital or in the clinic, and they need to be treated for combined fentanyl and xylazine withdrawal. And they're generally detoxed, and there's good literature coming out, especially from Philadelphia today on these days on new protocols for detoxification and the treatment of combined fentanyl and xylazine withdrawal. And now there's another issue that I like to insist on, that I think it's very important to insist on, and it's the fact that xylazine cannot be thought alone. It cannot be thought of as a discrete new substance that requires its own specific treatment. It needs to be thought alongside fentanyl because it's always together with it. And it also needs to be thought alongside this other new substance that I encountered in Philadelphia, again, for the first time in my life in 2021. I had lived in this neighborhood between 2008 and 2012. I had never seen this substance then. It's now basically everywhere. And that substance is methamphetamine. Back when I lived in Philadelphia, stimulants were really not very commonly used. Many or most of the corners that sold heroin also sold cocaine, but cocaine among people who use drugs was generally considered a treat to be done sporadically when you had money to spare on a binge, or you wanted to party a little extra or feel a new experience or a different experience. But with methamphetamine, methamphetamine is becoming increasingly used alongside opioids. Most of the people that I spoke to in the spring and summer of 2021 were doing both. Methamphetamine as a synthetic substance is kind of like the opposite of fentanyl, actually. If fentanyl was a synthetic substance that was more potent but shorter, and that actually has a high that users experience as qualitatively inferior, methamphetamine is the opposite. It's a synthetic substance that is longer lasting than any other stimulant available in the market. It's longer lasting than cocaine, and it is experienced as a full body experience of euphoria. And that partly explains its new popularity, especially given its purity and its cheapness. And the testing program that I mentioned in Philadelphia that is testing the opioid supply is also testing methamphetamine. And so far, all the data that they have reported on meth in 2022 shows that methamphetamine is the purest substance available in the street market right now. There's absolutely no adulterants in it, no fentanyl, nothing, which is very interesting. And again, this is specific to Philadelphia. This might be different in other cities, in other contexts, but in Philadelphia, that is the case, and that partly explains its newfound popularity. And the reason why I include these quotes here in the slide is that in my conversations with people who use drugs in Philly, I realized that meth has an analogous impact on the opioid high, analogous to xylazine. And again, this is another reason why these substances can't be thought as separate, like the stimulant has an impact on the opioid effect, and therefore needs to be thought alongside the opioids or the sedatives. And so you can see again in this quote that that meth has an analogous impact on opioids. fentanyl is so short-lived that we got to get high every 6 hours. But sometimes, let's say things were tough or whatever, if we were 10 hours in and you started getting sick, dope sick, right? A nice shot of meth will hold you over for another 6 hours. As far as not being sick altogether, you just wouldn't be as sick. I mean, eventually it would turn against you, but it would keep you feeling better to get up and make a move to get money. Then the next quote says something very similar. Most of the people who are homeless and use drugs in Philadelphia engage in nighttime income generating activities, scrapping for metal, trading sex for money, which is the most common activity among women. Meth acts like xylazine in that it gives people who use drugs an extra 3-4 hours. It basically staves off withdrawal symptoms for an extra 4 or 5 hours, allowing them to make more money to buy more dope. So I think increasingly about the increasingly synthetic polydrug context, right? This is how we need to understand the new harm reduction landscape. In Philadelphia, the advent of xylazine and fentanyl transformed pricing structures for the first time in 30 years. Between 1991 and 2020, individual bags in Philadelphia of dope were cost $10. They now cost $5. But because they are now comprised predominantly of fentanyl and xylazine and not long-lasting heroin, people who use drugs find themselves needing to buy more bags than they used to. And so thinking about the economic implications of this for both the supply side and the consumption side, I think will be important as we move forward. One dynamic that is very important, where the messaging is not going to be clear, it's going to need to be complicated, concerns the impact of all these transformations, the advent of all these new synthetic substances on HIV and HCV risk among people who use drugs. Because on the one hand, xylazine, in extending the fentanyl high, mimicking heroin somewhat, is driving people who inject drugs to inject fewer times throughout the day. And that means that they're reusing needles less, they're sharing needles less, and that has what we would call in the harm reduction world, I suppose, a positive impact in reducing HIV and HCV risk. On the other hand, meth is, as I mentioned earlier, driving people to work more and work harder. And for women, this means having more sex. And that is clearly going to increase the risk of HIV. So this new era is going to have a complicated impact on HIV and HCV among homeless people who use drugs. And my future research is heading in the direction of trying to understand exactly what the impact will be. These are such recent developments that we do not have the data yet to be able to tell exactly what the impact has been. Looking forward, what can be done, right? So what could be considered some proposals for this new harm reduction era? So as I mentioned earlier, the advent of xylazine and meth contributes to our insistence on the need for more overdose prevention centers or safe injection sites, not just on the basis that they prevent overdoses, but also on the basis that they are going to help prevent sexual assault for women who are homeless. These findings and this new context also call for the support for community-based gas chromatography and mass spectrometry testing, in addition to new technologies that are already being distributed, such as fentanyl test strips and xylazine test strips, which are kind of beginning to take off. But access to gas chromatography and mass spectrometry technology among people who use drugs or among harm reduction service providers would allow consumers to know in real time what is happening to the drug supply, what is the composition of the drug supply in a way that would allow them to act accordingly. Of course, needless to say, the advent of these new substances also supports the idea of safe supply of the prescription of safe opioids to people who have a dependence on them. One thing that I've begun to realize is that supplies are also they're sort of shooting themselves in the foot with the advent of xylazine and fentanyl, because people have used opiates for a very long time. Remember that heroin was superior in all these ways that I mentioned before: duration, the quality of the rush, the quality of the high. And so today, safe supply would actually be better supply, like unambiguously better supply than what is available on the street, which is this combination of fentanyl and xylazine. And that wasn't always the case. Between 1991, 2019, heroin in places like Philadelphia was incredibly pure. So pharmaceutical grade morphine or whatever it is that you can prescribe to people who use drugs at that moment in time wouldn't have been unambiguously superior to what was available cheaply on the street. But today it would be, right? And so that's one of the reasons one of the factors to consider as we continue to advocate for safe supply. And then this is kind of another direction in which my research is heading. I am very strongly advocating for the engagement of supply in harm reduction. We need to think about what supply side harm reduction would be. I was always a little bit surprised at the fact that my neighbors who had to sell drugs to survive were never really approached by harm reduction service providers who otherwise do such a good job reaching out to people who use drugs and take so many risks and are so courageously provide desperately needed services to people who inject drugs. But they never approached, say, a young street seller, right, commonly known as dealer, to see if they would be willing to carry naloxone or to store naloxone in their house two doors down from the corner, right? They don't even have to carry it in their pocket. To have clean needles in their house, right? And every single street seller that I spoke to, many of them were my neighbors, would have been thrilled to do that. They would be thrilled to have naloxone in their house. And eventually they'll be thrilled to have whatever reversal agent is invented for xylazine. And it's always been very surprising to me that we haven't begun to imagine that kind of non-punitive engagement with supply. We have relinquished the engagement with supply to law enforcement, to police, to the DEA. We need to stop doing that. We need to start imagining forms of non-punitive engagement, right? It's important not to vilify the street seller as though they were simply greedy economic agents trying to poison customers with substances like fentanyl. In most instances, I mean, in every single place that I have studied carefully, including the mill towns of Massachusetts, Huntington, West Virginia, Philadelphia, dealers have had absolutely no role in the adulteration or mixing of substances. They receive their substances prepackaged from 3 steps up in the supply chain, and don't even know what they're selling. And so it's very important not to vilify them and to try to find ways to engage them non-punitively. And that's it. Thank you very much.
Thanks, Fernando, for sharing that really important work with us. We will jump into the Q&A portion now. We have some questions already. I assume this one applies to folks who administer xylazine orally. Victoria Murray asks, have you ever seen any wounds or dental health patterns in the oral cavity in people using xylazine?
Oh, that's a great question. the thing is, the dental issues that people have today don't seem all too different from the ones they used to have before. Again, most of my research is among homeless people who use drugs. And so I, as a non-clinician and as a non-doctor, I would not be able to give you a good response, but I think that's a very important question. Yeah.
Sure.
Sorry.
And to clarify, my apologies, Victoria, it's not just for oral administration. She says we see xylazine wounds popping up peripherally.
Yeah.
Okay.
Yeah, even that the public health literature in the 2000s was insisting that the skin wounds are extra local, right? That they don't always appear in the site of injection. And again, people who sniff exclusively are getting wounds too.
We have a question from Jeremy Kidd. I know that you mentioned xylazine can cause ulcerations even snorted or smoked as opposed to injected, but I wonder if we know if there is any difference in the incidence of ulcers depending on how xylazine is used. And then secondly, are there models that supply side harm reduction in other parts of the world?
Great. Yeah, these are fascinating questions. Again, the first one will require more research to be able to answer. I am rushing through an IRB protocol right now to try to continue doing qualitative research in Philadelphia. So I haven't been able to investigate these distinctions, but this is as I move forward, this will be a great question to ask, to try to separate out the kinds of people who use drugs into people who sniff and people who inject, and see how all these health conditions associated to xylazine differ depending on what group I'm examining, right? And then supply side harm reduction in other parts of the world. I can't think of many, to be honest, right? And we could definitely imagine not just these simple interventions that I was mentioning, kind of like giving naloxone to people who sell drugs to store in their house 2 doors down from the drug corner. We could imagine also ways of engaging higher levels of the supply, at least in order to be able to test the supply more quickly and more efficiently in a way that would be positive for public health. Right now, there are surveillance programs in this country that, the DEA spends enormous amounts of resources sending agents to buy drugs all over the country multiple times a year. I mean, thousands of times a year. They're doing a really lousy job analyzing that data. The reports they write are published with a 6 or 7 year delay. The last report that was published was from 2016, and it was published in 2018. So the last DA report doesn't even respond to the question of fentanyl or the question of xylazine. And I think we need to wrest away those capabilities, those resources of testing and monitoring from law enforcement, right? Public health just needs to take over. Harm reduction needs to take over that as forcefully as possible. And one way to do that is to imagine these kinds of non-punitive engagement with supply. Right. But in terms of models that exist in other parts of the world, I'm not aware of many.
Thanks, Fernando, and thanks, Jeremy, for your question. Karen McKinnon writes, in terms of harm reduction, there's a lot of messaging that needs to happen in the community because OPCs are gathering good evidence of averting overdose deaths, but there are camps in the substance use treatment world that oppose OPCs as encouraging continuing use rather than abstinence. These perspectives from so-called experts are frequently trotted out on New York One, for example, and fuel opposition to these needed sites. Have you seen good community infographics that present the science in favor of OPCs?
Yeah, I mean, this is an endless debate. This is the perennial debate if in the field of harm reduction in general, right? Even providing clean syringes is often presented as encouraging drug use, right? And you all must be aware of the fact that public health and harm reduction have had to fight and debate that question for forever, essentially, right? And that same question is reappearing now with overdose, with the emergence of some overdose prevention centers and some projects to develop them. Philadelphia went through one of these debates very recently. Philadelphia was supposed to be the first city in the country that was going to install an overdose prevention center in the neighborhood of Kensington. But this was all during the Trump administration, and there was clearly an articulation there, some a combination of federal interest in opposing the overdose prevention center, and a lot of kind of like fanning the flames of and alarming community members in ways that created also some local opposition to the centers. But I mean, all the data from places where overdose prevention centers have been instituted, Canada, places in Europe, show that overdose prevention centers have significantly reduced the levels of overdose and even the levels of crime in the cities where they have been installed. But no, feel free to email me, and I can always share articles and data that has been produced in the places where overdose prevention overdose prevention centers have been implemented.
Great. Thanks, Karen, for your question. We will end with a final question from Teo. Teo, go ahead.
Fernando, as others have said already, wonderful presentation, very informative. I feel like you're bringing a whole new level of knowledge to our group, which is very important. So thanks. I have one question about that supply side harm reduction idea. Because in a way, I feel like it sounds so obvious. Why hasn't that been done? But I also wonder about the legal implications of an activity like that. Have you thought about that, or is that part of where you're going?
Yeah, I mean, at every level where you could possibly imagine this, there would be obstacles related to, well, you know, the dominance of law enforcement logics in this country, right? Like, you know, one of the reasons that harm reduction service providers are often scared to interact with drug sellers is the fact that that kind of engagement is criminalized, right? Like, even in the course of doing my research, I was detained dozens of times by police officers. I was raided twice in Philadelphia because the police assumed that if I wasn't calling the cops on the dealers, it meant that I was colluding with them or collaborating with them in some way or harboring them when there was a raid. And so just walking around the neighborhood is in itself kind of risky for harm reduction service providers, and that's a huge obstacle in producing this kind of engagement, right? Also, the fact that police in places like Philadelphia still consider syringes or even fentanyl test strips to be drug paraphernalia, and people get arrested all the time for carrying those things. So harm reduction service providers aren't just running around with those things, and drug sellers might feel wary about having those things in their pockets, right? Which is why I'm proposing that they could store it in their house 2 doors down from the corner instead of carrying it around, right? Yeah, and then in terms of engaging with higher levels of the supply, I can imagine all kinds of obstacles, and this is something that the activists and scholars that have been inventing new testing programs are having to think through very carefully. How do we get samples in a way that will not be that will not make us liable to criminal prosecution, and that will also go through an internal review board, right? And so, you know, there's a program at the University of North Carolina, Chapel Hill, that has come up with a whole methodology for obtaining drug samples in a way that would stand up to any kind of criminal scrutiny or criminalizing scrutiny. They have come up with a substance that effectively neutralizes the narcotic that they're going to test, and so they take this neutralized substance back to the lab and test it, and they're able to show what the actual composition of the supply looks like, right? So I mean, it really will involve a whole reimagining of research, but I think it's exciting, and I think it is absolutely possible. It's just, it does need to be done with imagination and with assertiveness.
And it requires political change.
Absolutely, yeah.
Well, good luck. It sounds very promising and very adventurous and very relevant and much needed. Thanks.
Thanks, Teo, for your question. There was a request for your email address for more information, so I just entered that in the chat, Fernando. Thank you everyone for participating in the Q&A. Bob, I'll turn it back to you.
Thank you, Stephen, and thank you, Fernando. That really, like everyone said, that was really very rich and really important and timely and cutting edge work. So thank you for sharing it all with us. And you can see there's a lot of enthusiasm with the questions and discussion, which I think could have gone on much longer. So thank you both, Fernando and Emily, and also to Dennis. And we look forward to seeing everyone at our next grand rounds on February 23rd. Take care, be well, and hope to see you on the 23rd. And thanks again to today's presenters. Bye-bye.